missing a few.
Lawrence came on. Yeah, Lawrence came on.
So all first year residents? Okay. Great. Glad to have you. Barry Campbell, maternal fetal medicine over Department of OBGYN. I'm also the chair of the department. So happy to be here with you guys. I don't run across you hardly ever. So this is a rarity. And I'll probably bore some of you with some of this information, but it hopefully will be applicable to what you guys do in the future. I'll be glad to answer questions. So are others are zooming in, is that right? Or do they just record this and it's mainly you guys?
It should be.
Okay.
As far as I know.
Yep, I see some people. All right.
Yeah. If she wasn't so late another night, she could have hung out with her. You know what? I need to take.
You know, no hard.
I can show myself something else. I just need to laugh. If it's not like that. He's like, we're I literally can't. I can't move. You know, babe, I can't move. I think that's invalid reason. It's important. Couch is great. We love dogs. Dogs are all about them. Goldie like lives in the little corner. She goes to the store.
So if you guys are okay with it, I'm going to go ahead and get started. And we'll try to respect everybody's time. And so anybody that's on the Zoom, I'll try to pay attention to the chat box, but I'm not really good at that. So I'll do my best. But anybody here, please feel free to ask questions as we go along. And like I said, a lot of the stuff that we're going to do may not be directly applicable to you guys, but you will come across much of this when you take care of the children that we deliver for you. So I'm going to talk about management of suspected fetal anomalies. So it's a field that I deal with every day. Just the objectives. We're going to talk about screening methods, some ultrasound, accuracy of the screening methods, diagnostic testing. You guys all learned this when you were on the OB rotation anyway. We'll go through some cases that some of it's more applicable to you than others, and then we'll talk about some ethical dilemmas that we are dealing with more and more when we have patients with babies with anomalies. So get right into it. Birth defects represent about 3% of our births. So it's a fair number. If you look to the right, chromosomal abnormalities are the ones that get the most attention, but only accounts for about 10 to 15% of birth defects. And these are common board questions as well. Prenatal exposure, such as CMV, toxo, infectious, radiation, etc., 8 to 12%. Single gene disorders, 2 to 10%, depending on what population you're looking at. But multifactorial, what are some examples of multifactorial inheritance disorders? Neural tube defects, gastroschisis, things like that are multifactorial. In other words, it's just like a coin toss. It does increase risk in subsequent pregnancies, but then almost 50% of birth defects are unknown etiology. So it's pretty significant. So if you look at the prevalence of chromosome abnormalities, by far the most common is trisomy 21. And there probably are others that you don't see but end in miscarriage. But as far as the ones that make it to a living birth, trisomy 21 is by far the leading, followed by T18, T13. The sex chromosome abnormalities are fairly common. The sex trisomies are pretty uncommon. So when we talk about screening and testing, we talk about when to do it, first, second, or third trimester. There's first trimester, we'll go through some of these in a little more detail, serum and ultrasound screening. Second trimester is primarily serum screening. All the way through pregnancy, from about 8 to 10 weeks on, you can do non-invasive prenatal testing or screening. And that's something that you guys are probably more familiar with. And then the diagnostic testing, CVS and amniocentesis, and we do those at different gestational ages we'll talk about. You don't need to know this slide, but it's just to show you the myriad of screening options that we have. They can include ultrasound, doing the nuchal translucency, or it can just be serum. But if you add ultrasound to the serum screening, it increases your detection rate. And the best detection rate you have is about 95% serum marker. Somebody is not good. There we go. And we set the test to have about a 5% false positive rate. So that's just the amount of error that we will acknowledge that we're going to have, so that you don't over detect or under detect at a greater level than that, so you have fewer false positives. Now, non-invasive prenatal testing it's a great test. It reduces the false positives and increases the ability to pick up chromosome abnormalities. And it's around the premise of detecting cell-free DNA in the maternal circulation. It's pretty cool technology. It's getting better and better. 2 to 20% of the total cell-free DNA in mom's blood is from placental origin, a cytotrophoblast, and it's released into the bloodstream by cell death, and you can detect the cell-free DNA as early as 7 weeks. With the peak,
I don't know if this is on the
everybody mute if you would.
the phone.
Thank you. The peak is about 10 weeks gestation, so you can see increasing in the amount of cell-free DNA as the pregnancy goes. So who gets NIPS? Well, American College of OBGYN and Academy of Pediatrics recently came out with a joint statement that all patients should be offered NIPS. We used to offer it only to the high-risk moms, advanced maternal age, previous chromosome abnormalities, birth defects seen on ultrasound, but now we offer it to everybody. Now, insurance companies are lagging behind a little bit. They're not paying for it for everybody yet, but hopefully with the pressure of the societies, that will pick up steam. Amniocentesis done between 15 and 20 weeks, and CVS is done between 10 and 13 weeks. Those are the diagnostic tests. They give you the answer. The screening test, all the blood tests that we're talking about, and non-invasive prenatal screening. Just remember, the only thing I want to just mention again about NIPS is it will not pick up all abnormalities, and not all positives are true positives, and not all negatives are true negatives. However, I will say, if NIPS comes back negative for Down syndrome, the negative predictive value is so good, we quote a 99.99% negative predictive value. So that's a big deal. And it's very reassuring to patients. But it is not 100%. Why isn't it? Well, don't forget that placental mosaicism is a real thing. And now that we've learned all we have about NIPS and through CVS, we know that up to 15% of placentas will have mosaic cell lines in it. So if you get trisomy 13, that's why you get a trisomy 13 and have a normal ultrasound and a normal amnio later. it's because of the placental mosaicism confounding the results. In your slides, there's some educational resources that give you more information on NIPS. Again, just letting patients know it's not 100%, that is the key. Now, and this has just happened in the last year, is that the Society, Medical Society of Genetics has strong-armed the companies that report these to actually provide a positive predictive value with every test they get. So if I get a positive T21 NIPS in a patient that's younger, as you can see here, 23-year-old, positive predictive value is 50%, and a 43-year-old positive predictive value is 97%. So you link the age, any other risk factors the patient has with the positive test, and it increases that positive predictive value. Philip, I don't think you're muted, just to let you know. Now Rachel is not muted. All right, let's go on. We'll try to get them to mute. So is there a place for routine serum screening? Even if you wanted to do NIPS, is there a reason to do the other blood test? And the answer is yes, and that's because the serum markers, when they are falsely positive, are associated with other pregnancy poor outcomes. So it helps us identify a group of patients that need to be watched more carefully. And when I talk about poor pregnancy outcomes, I'm talking about preterm labor, preeclampsia, stroke, fetal death, and even maternal death. So it helps us identify these. One of the tests that I think is most helpful, I've got 3 patients in the hospital right now with complications that are associated with an elevated AFP. So if you have an elevated AFP, more than 2 multiples of the median, they have a very high association of bad outcomes. So it just helps you counsel those patients more completely. The other thing with NIPS, and one of the reasons that it can fail, is poor detection of fetal fraction. So can you think in our society right now, one of the reasons you would get a poor fetal fraction in the maternal blood? It makes sense if you think about it. Obesity. That's the leading cause of poor fetal fraction. But in those patients that have poor fetal fraction, there is a significant increased risk of poor outcomes as well. So it's important to know that. Other things are medicines. Lovenox, for instance, decreases the fetal fraction. We really don't understand why that is. Diagnostic testing, CVS and amniocentesis. We traditionally have done karyotypes on these babies, just to look at the chromosomes. But importantly, now we're doing more microarray analysis, and it still will give us the karyotype, but it allows us to look for those copy number variants that are associated with many, many syndromes and other disorders that we've never been able to detect before. So in children, for instance, for you guys, if you have to order or need to order a test, we are very encouraging of skipping the karyotype. It's not all magic with karyotype. Do microarray analysis, and they can get the karyotype from that. So that's what we suggest to do anytime we're testing, either after birth or before. And particularly, if you have abnormal ultrasound findings, we like to do the microarray analysis. So the first case, 28-year-old G1 comes in at 13 weeks with a positive NIPS for T13. So what do you tell this patient? What do you think? So she's 28, so that's a young patient. T13, I don't know if you remember, but as we were going through, I said T13 has a lower positive predictive value with NIPS. So it's probably going to be low. If you calculate it by our mechanisms, positive predictive value is only 38%. So you get this mom, she comes in, she's all torn up. Her baby has T13 in her mind. And her referring docs have told her that. So they've scared her to death. It's really low, so then we'll do our workup, which is diagnostic testing and ultrasound. What's the positive predictive value if she's 41? Well, then it goes up, but it's still not 100%, not even close to 100%. So there's still a chance that it's going to be normal. Now, this is the key, and this is what I tell patients. If I see a patient with this blood test, but the baby looks normal, I'm very reassuring to her. Why is that? Because with T13 and T18, remember this, those two defects almost always have some abnormality on ultrasound. So if you see a normal fetus with an abnormal test, you got to ask yourself, is this real or not? How about a 23-year-old with a NIPS positive for Turner's 45XO? What would be your guess? You think it's really a good positive predictive value? Didn't talk much about that. It's really not. It's only a 19% positive predictive value across the board, really. But what if you see this ultrasound picture? Now, I know you guys don't do ultrasound, but this is the little head, this is the baby's body, and this is the nuchal translucency. And I can tell you that that's not normal, okay? Now, this is that same fetus, and this is a transverse image of the neck. What is this? And this is the chest, and this is fluid in the chest. This is fluid in the soft tissue. This is a cystic hygroma. So when you see the cystic hygroma, you know that there's an increased risk of aneuploidy. Turner's is the most common, followed by T21. But at least 50% will have an aneuploidy. So with a positive NIPS and ultrasound findings, positive predictive values over 90%. But it still requires a diagnostic test. So let's say this mom doesn't want genetic testing. What do you do, and does it matter? Does it affect your counseling? Does it affect the prognosis? And really not. So when you see a severe cystic hygroma this early in pregnancy, it's basically associated with 100% poor outcome, lethal. And they develop heart failure and high drops. And most of these are losses by 24 weeks. But the key is don't assume, and even though we know by looking at this pregnancy and seeing the NIPS and knowing that it's not 100% positive, you need to send tissue after delivery or termination, whichever they choose, to confirm that diagnosis. And why? Because it helps in their future pregnancies as well. Remember talking about recurrence risk. So it's very important for the mom and the parents to understand that and to know it. Next case, a 42-year-old, 12 weeks with NIPS positive for T13 or T18. In this patient, without ultrasound, the positive predictive value is 75%. So now we're back to an ultrasound of this fetus, and you can see the total body edema in this baby. Now, you may not appreciate this, but this is a classic finding with T18, and it's clenched fist. So you see the fingers are kind of crumpled on each other. So your positive predictive value has gone up. Now this is a heart, and this is in a view of a normal 4-chamber, but this is not a normal 4-chamber. It is a hypoplastic left heart. You don't see a ventricle here. So you add abnormal ultrasounds, it increases the positive predictive value. Again, you need diagnostic testing. Amnio confirms this. And just remember, particularly with T18, heart defects are seen almost all of those babies. CPCs, clenched fists, renal, brain abnormalities, and growth restriction. This is not as much for you, although it does impact if you've got this, if you're going to be the pediatrician taking care of these babies. Because used to, we thought these babies all died right after delivery, right? And we'll talk more about that in a little bit. But in labor, should you offer this patient fetal heart rate monitoring or not? So what does the heart rate monitoring do for us as obstetricians? And for you as pediatricians? So it helps me know whether I want to do a C-section for fetal distress, right? And it helps you know if she wants me to monitor this baby, this is when I get the wide eyes and the question marks from pediatricians. Is I said, what the hell are you doing? Why are you doing a C-section on this patient? So why would you think you would do an interventional surgical delivery for a patient like this? What would be the reason? Any idea? I'll tell you, times have changed, because I used to, in a former life, would say, we just won't do a C-section in this situation. We just won't do it. But now we've really started doing them more for these patients. There are lots of reasons. I tell you guys, I can't reiterate enough how parental involvement in their pregnancies has changed our management in these cases. 9 out of 10 women who want to be monitored and will have a C-section for delivery just want to have a live born baby so they can bond with the baby, or have baptism. There are many reasons, and we'll talk about some of them that are really extreme a little bit later on, but that's an increasing number of patients. So for you guys particularly, I think, and it's one of the things that we do here, getting neonatology involved early on, have them come down and talk to the patient. What does doing everything for your baby mean to you? Well, if I ask a mom, do you want to do everything for your baby? Well, what do you think they're going to say? Everybody wants to do everything for their baby. I mean, that's just un-American, right? It's just not right. So you have to be careful how you ask the question. Sometimes doing everything for the baby is doing nothing. I mean, that's the better thing. You want to prolong suffrage, pain, you do everything that as doctors we think about doing everything, tubes, IV, things. That's not necessarily what we need to do. But the real question is whether to do those C-sections or not. And we really do a lot of directive counseling in these patients, but the ultimate choice is theirs. A 19-year-old referred for severe limb shortening at 19 weeks gestation. This is always one of my hated cases. I just dislike these so much. Negative history. So this is the little head. Anything to look abnormal to you novices that are not really reading ultrasounds, does that look normal? It's kind of wide, and it's called a strawberry skull or a clover leaf skull. This is a femur, and that's definitely not normal for 19 weeks. It's got that telephone receiver look. Here's the other femur. You can see how short they are. And this baby has real, what we call frontal bossing, where the frontal bones are just so large. Anything about that chest look abnormal to you? It's a bell-shaped chest. So what you worry about when you see this with skeletal dysplasias is pulmonary hypoplasia, because you see same shortening in the ribs that you see everywhere else. So you have this baby that can't have normal pulmonary development. There are so many types. That's one of the reasons I hate these, because they're so difficult to come up with a definitive diagnosis before delivery. And some of these that look really bad, the babies have very good long-term survivability. Not, so I didn't say good outcomes, but survivability. That means they can live into their 40s but they're bedridden and taken care of like a baby. So it can be quite severe, even though they might live. And that's something that patients need to understand. The chest size is probably one of the more important things to look for pulmonary hypoplasia. Look for other things, confirm with genetic testing. This particular patient had agreed to an amnio because we do have a skeletal dysplasia panel. And the panel tests for like 40 different types, but you can't just order the skeletal dysplasia panel because it would take the entire duration of the pregnancy to get the diagnosis. So what you try to do is hone it down by your specific findings, like the strawberry cloverleaf skull, bell-shaped chest, and severe micromelia. All the limbs were short. And it kind of led us to testing for thanatophoric dysplasia first, and it was positive for that. And it is 100% lethal. So then you can talk about pregnancy termination as an option for these patients. This is the problem, and this is why I think as pediatricians and as obstetricians, we're seeing more and more of these patients continue these pregnancies. They don't have the money to terminate pregnancy. And no insurance, private or government paid insurances, will pay for pregnancy termination for fetal anomalies. And that is just not right. This patient goes routine care. Same things you have to go through. Do you do a C-section? Not. These are patients that I definitely don't recommend any intervention for at all. Case 5, a 24-year-old sent for a possible ventral wall defect at 19 weeks. Normal prenatal care. The NT was normal at 11 weeks, and all prior pregnancies were normal. You can see that this little head is normal, and then you go beyond the head, and boy, it just goes all awry. This is not normal. It is stuff afloating everywhere at 19 weeks. This picture's interesting. If I had this in motion, you could see this is actually the heart on the outside. And this is the entire abdominal contents, really open from just mid-sternum all the way down to the symphysis. Arms, legs, hands, feet, totally normal. Any ideas what it is? Well, it's related. It's related, but it's bad. Yeah, it's a bad one. Yeah. We offered testing, and this is the key. Understand that most of these birth defects, these structural defects like this, aren't necessarily related to a chromosome abnormality, okay? It's freestanding, so to speak, and it's just an ultrasound finding. But just because an IPS is normal doesn't mean the prognosis is better, right? I mean, if everything's out, including the heart, that's not a good thing. It's called a pentalogy of Cantrell. Pretty rare disorder, although I've been in Columbia 5 years. I've seen 5 cases of this, more than I've seen in my career out here in Columbia. So it's literally a defect in the pericardium, diaphragm, heart's out, everything's out. But the spine, everything else is normal, and limbs are. It's really a crazy looking abnormality. Lethal. Most of the time, you can have less severe cases that have been associated with ability to close it, but that is the exception. A 32-year-old G1 at 20 weeks, first trimester scan at 8 weeks was normal. AFP is 6.9 MOM. So what is elevated AFP associated with? Neural tube defects. What was what we just saw? A rip roar and what? Gastroschisis or omphalocele. Okay, ventral wall defects and neural tube defects. And when you see an AFP this high, you're automatically thinking this is not going to be good. Also can be associated with fetal demise because AFP increases in mom's serum. A large maternal fetal hemorrhage is also a common cause for this. It's not something we see a lot, but certainly can cause it. And then placental implantation disorders, where the placenta acts like a cancer and grows into the wall of the uterus. Everybody know what this is? This is a board question for all doctors. They'll expect you to see this ultrasound. Looks like ET. The orbits and nothing above it. Anencephaly, okay? Anencephaly. And these are all lethal, but you know, they don't, just because it's lethal doesn't mean they die immediately. We used to think that, but most people would terminate. We've had a couple of patients here who've taken these babies home with hospice care. So it's something that we're seeing more and more. Multifactorial, so remember multifactorial traits are about 1 in 1,000 for birth defects, but if you have a child with a multifactorial trait, the recurrence risk is 2 to 5%, okay? Don't forget the folate. Even as a pediatrician, you guys need to, if you take care of a mom and she's had a baby with a neural tube defect, do you understand the need to folate supplement for other pregnancies? Very important. Routine scans will pick that up. And we've got one right now that's got a baby with anencephaly, and she's 33 weeks, and she's really talking about wanting a C-section for a live birth. It's a constant struggle. This is a slide that I just wanted to share with you guys from a recent study, because I told you that most patients with these abnormalities would opt for termination, but now that we're seeing more and more that continue the pregnancies, we're learning that most of these babies actually do make it to term and have live borns. You'll have this slide. What I wanted to point out to you is the stillbirth risk is in this third column for each of the different types of abnormalities that we see. And there is definitely an increasing risk of stillbirth with structural abnormalities, even cleft lip, cleft palate, but it is nowhere close to 100 or even 50%. These pregnancies will make it to term not infrequently. 39-year-old at 18 weeks has a NIPS high risk for T21. So with just the age, her positive predictive value is 82%, but it goes up to 99% with an abnormal ultrasound. And this patient showed two things that are so commonly seen with T21. Increased nuchal fold on the left, and this is an AV canal defect. The center of the heart on the 4-chamber heart is missing. And that's really the sine qua non of Down syndrome. When you see that, you have to rule out Down syndrome because it's so common with that. So if you've got everything that's pointing to T21, do you really need to stick a needle in this lady's belly and do an amnio to confirm it? So is there any drawback to amniocentesis? What's a drawback besides the pain? I wouldn't want a spike in my belly either. What's the drawback? Small risk of miscarriage. The risk is 1 in 500, but it is a real risk. So if the patient says, I do not want to take any additional risk for my fetus, I don't want the amnio. So is that okay then? Yeah, I mean, you're pretty certain that's what you've got. So what do? You do testing after delivery. So you do need to do the testing to confirm it, but you can do it on the baby. And in the meantime, most of these moms want everything done anyway as far as interventions with heart tracing and so forth. T21 has been complicated in the past, but nowadays everybody wants interventions. And ethically and morally, a lot of debate on whether it's 100% required to intervene for distress for a T21, but most people feel that it is. We won't get into that. Another ventral wall defect, at least is what they thought, NIPS was low risk. So this brain looks normal. That's a beautiful little cerebellum. Face looks normal. But then you look at the spine, and the spine kind of disappears. So you've got some cervical spine, but it goes away. There's nothing. This is where the lumbar spine should be. This umbilical cord is attached right here to the wall of the uterus. And this is just not right. I mean, the baby, this is a cross section of the thorax, and this is the lower part of the body. So it's like the baby is jackknifed on itself. And this is something called a limb body stalk anomaly. Have y'all ever heard of that? Some of you that were students here, we've had 10 of these cases in the last 5 years. It's really crazy because it's pretty rare. It is multifactorial. And in this case, instead of just the ventral wall defect in the normal fetus on the backside, these babies have the inside totally open. The spine is abnormal, and the baby is fused with the placenta. So there's no umbilical cord. There was never any separation. So the baby and the placenta are one. And these babies are frequently born alive. As a matter of fact, 5 out of the 10 that we've had have been born alive here, and they pass away shortly after delivery. But the fetus is just really abnormal. Go through this. All right, NIPS positive for T13 in a 38-year-old G1. And the ultrasound is normal. 19 weeks, we see a VSD, nothing big. Borderline ventriculomegaly in the brain. And the amnio showed mosaic pattern. So it's not just placental mosaicism. So this is a true mosaic for trisomy 13. So this mom comes in to see you prenatally to say, what does this mean for my baby? What do you say? I mean, the ultrasound's pretty good. Okay, so a VSD, I mean, babies have VSDs all the time. It's not a big deal. And really, the baby looks normal otherwise. What are you going to say? That's exactly what you say. You don't know. You don't know what to say because there's no data to support really any counseling. And this was tough because, you know, T13 is bad. And wanting to know whether she should terminate the pregnancy, whether she should have expectant care. There's just very little information to draw support from. And this patient actually delivered here last year, and the baby was totally normal. We did blood chromosomes on the baby, and the baby's serum showed 13% trisomy 13 cells. And that child is a year old now and meeting the normal milestones, but is a mosaic for T13. A lower level, but still 13%. That's still significant. So we don't know. We'll see. We're going to do a case report on this one. This was a tough case, and I put it on here just because I think this is one that we had in Columbia about 3 years ago. Hypoplastic left heart. Fetus was normal. Chromosomes weren't done, but she did have NIPS that was done. And the patient desired, somebody's not muted out there if you would please. Somebody, so she didn't want any intervention, i.e. didn't want to deliver at a center where they can do heart surgery on the child, and just wanted to let the baby pass after birth. Is that a reasonable option? What do you think? That's an ethical and moral time bomb, isn't it? And we struggled with it. But the thing that you have to understand, yes, question. Yeah, the question was, did she discuss abortion as an option? And the unfortunate part, and this is one of the reasons it's so important to not miss the diagnosis. It was a late diagnosis. So it was beyond 22 weeks that it was detected. She would have terminated. She would have terminated the pregnancy, no question. And she was a healthcare provider too, I will add that. So she's very well informed. It is, so that's where you take the moral high ground. Oh, well, yeah, it can be fixed. You just got to fix it. But the impact that has on family and on that child, not to mention the success and failures of the procedure and the torment that you go through the first 2 years of life and then the baby dies. I'm not taking one side or the other, but I can tell you that we see hypoplastic left heart with no other abnormalities treated a lot, and the babies end up doing well. But the road from diagnosis and birth to doing well, it's a long, arduous path. So what do you say in these situations? Is really, really hard. And that's one of the reasons I always am after obstetricians to do a better job at diagnosing heart defect. Because this is a big deal. At least if she wants the option of termination, you've got to diagnose it before 20 weeks. And this is something you should be able to diagnose before that. And she did deliver, took the baby home. And these babies do great for a while, right? How long do they do great? Until the ductus closes, which can be 2 days or a week. And it's gut wrenching. You can just imagine. And again, just to mention, termination is becoming less and less frequently done. And it has a lot of things to do with cost. It has personal choice, and lots of other things. Site of delivery depends on their patient's desire for interventions. Another reason that we deliver a lot of these lethal abnormalities here is because of our palliative care services. If I have one of these patients that they're taking care of in Kershaw, for instance, small labor and delivery, they just not only don't want to deal with it, don't know what to do with it, and it's just easier to send them to us. So we take care of a lot of these patients here, but certainly they can come in, show up there, and deliver, particularly on you guys one of these days when you're out there. One of the other problems, and like I said, with the skeletal dysplasias, the prognosis can be very difficult, to say the least, at nailing down. So controversies in management, you just have to talk about what you know, you understand, let them know that you don't know everything. Sometimes they might do better than we expect. We do give the offer them termination in these situations, even if it's not a lethal abnormality. If it's an abnormality that's going to require a lot of interventions, important for them to know their options, regardless of what my belief is or your belief. They've got to know what their legal options are. I don't have to do it, but I need to be able to refer them for that if they choose to follow that path. So lethal abnormalities, anencephaly, body stalk anomaly, most pentalogy of Cantrell, likely lethal. It's just so hard. Long-term survival is not good for T18 and T13. And the life expectancy often depends on whether there are other abnormalities. And it's a changing paradigm out there, because I'm going to tell you, there are people doing crazy things to these babies with what we've always considered lethal anomalies. Yeah, this is me talking to patients. So there was this paper published from very reputable centers that I just had to shake my head at, but looking at the survival and surgical interventions for babies with T13 and T18. So what they did at these centers gave the patients with these diagnoses the option of operative repair of major congenital anomalies like heart defects, spine defects, other surgeries that are big deals in babies with diagnosis of T18 and T13. In these groups of patients, the 174 T13, 254 T18, the T13 one-year survival rate is 19, almost 20%, and 10-year 12, almost 13%. The T18, 13 and 10% at 1 year. And the median survival for T13s are almost 13 days and 9 days for T18. And the reason you see it lower with T18 is they typically have more severe anomalies. Surgeries on the T13, they did surgeries on 24% of the T13 babies. And the survival after the first surgery was 92 days. Median 1 year was 70%. T18, they operated on almost 14% with survival at 1 year of 69%. And it's really, the question is, are we just doing too much? What is survival? If the treatment is futile, I don't think, and most ethical authorities don't think that you should offer treatment. Now, the real question, neurocognitive deficits, if the survival is high, but it's associated with severe deficit, are we obligated to offer them interventions? Are we? It's one of those things where it would make it easier for me if we had socialized medicine, where they say, no, you can't do this. That's the benefit of socialized medicine. But in these scenarios, you have patients who don't have a lot of knowledge, and you counsel them extensively, but the actual reality is that they still don't grasp it. And it's those patients that want every surgical intervention done. And it's the way I counsel patients is sometimes we inflict more harm, pain, suffering to children by doing these things than we do just leave them alone and let them pass. And I think it's the way you counsel that makes it so much more important. Quality of life, way too vague, it's subjective, and it's not a useful argument. You have to look at parental values, but boy, again, directively counsel. Y'all don't even know what Old Yeller is, do you? Yeah, that's all right. That is all I have. Do you guys have any questions for me about anything I've told you? And you're welcome to these slides if you want. Yes, definitely. Definitely. And that's a hard one. That's a hard one because we don't really understand. She has actually gone through a lot of genetic counseling, and it's believed that she probably has a mosaic cell line in her oocytes and not truly every body tissue, although you could biopsy. That's the problem with chromosome abnormalities, right? Chromosome abnormalities affect every cell in the body when you have T13 or T18 or whatever it is, and that's why it affects every organ. But in her, it is suspected that she has confined mosaicism to her ovaries. So, but yeah, it's going to be a hard one, and she will go for genetic testing. She wants everything done, CVS, amnio, the whole gamut. And we didn't really talk about cord blood sampling, but sometimes we'll even do cord blood sampling when the results are very confusing, and that can give us better information prenatally. So, anything else? Yeah. Yeah, we'll cell-free DNA, NIPS be the gold standard and accepted by insurance. And I think it will. I think it will be very soon that will be the case. My fear with NIPS is that people will assume it tests for everything. And I'm not talking just patients. I'm talking doctors too. I can't tell you the number of doctors that I'll call and tell them that we picked up this or that abnormality, and they said, but her NIPS was normal. And it just goes right over people's head. You put too much stock on that result. I think it's a wonderful advent. It gives good information, and heaven's sakes, it helps with gender reveal parties, right? So that's what it's all about. But you just have to make sure parents understand it does not detect all abnormalities. That's the key. Remember, chromosome, only 10 to 15% of birth defects, right? Whole gamut of things that don't have anything to do with that. So it's helpful, and it will become standard of care, I guarantee you. But I think we're losing the forest for the trees a lot of times with that. So, well, thank you all very much. It was fun coming over. Come visit us on the OB floor. We'll let you deliver a baby.